Hello, hello, everyone. Thank you so much for coming. We are just getting started here today. We really appreciate you taking the time out of your day. Please, as you come in, feel free to introduce yourself in the chat. Let us know what state you're coming in from, if you're a CHW or an ally. We'd love to get to know each other here a little bit. My name's Aurora Grant Wingate. I'm a community health worker ally. I'm based in the Boston area, and I work for the National Association of Community Health Workers as their member and partner engagement manager. And today, before we hand it off to our speaker and our topic, I'm just going to spend a few minutes talking about NACHW and some new resources and benefits we have for everyone. So as you may know, NACHW's mission is to see community health workers united nationally to support communities in achieving health, equity, and social justice. And we are a young organization. We are still getting it together here. We are looking forward to our 5-year anniversary in April. As you folks are coming in and introducing yourselves in the chat, let us know how long you've been community health workers or how long you've been a part of NACHW. And we are really working to educate CHWs, allies, and supporters. We want to educate folks on topics far and wide related to community health workers, including our topic today around what different states are doing in terms of Medicaid reimbursement for community health workers. And we want to be a space for community health workers to come together so we can better do collective action and establish CHWs as a real national voice for their own profession. And again, talk about sustainable financing strategies and other larger issues related to sustainability that folks are experiencing across the country. And then lastly, to enhance CHW leadership skills and opportunity. And on that note, I'm going to hand it over to my colleague Tasha to talk a little bit about some opportunities and benefits that we have for membership.
Good afternoon, everybody. My name is Tasha. I'm the CHW Network Manager here with NACHW. Thank you guys so much for joining us. And so some of our membership benefits are you have an opportunity to join one of the boards, one of the 5 boards that we have. We also have our members only newsletter, and that members only newsletter is where we share news about what's going on with our members. This year, you will be able to see different highlights of the work that our CHW members are doing out in the community. So you will have probably already saw where we've asked for calls for CHWs to share their success stories. And so that's a new opportunity that we have. And then also we are asking that you let us know what events you have going on. If you have policy days, awareness days that you're implementing into your organization or your community, we want to know because we want to be able to highlight all of the beautiful work that you're doing. We also have a dedicated space to store and organize your CEUs. Many people are not aware of this, and I know this is something that many of us have asked for and need, a place where we can store our CEUs. So we have that on MemberClicks, as well as we offer CEU certificates for attendance, discounts for our Unity Conference. That's our annual conference, and also to be an ambassador. So there's so many more benefits that we offer, and we're really excited to be able to implement that for 2024. So our speaker for today is Ben Tinsvall, and he has been the lead contact for the CHW Collaborative of South Dakota since the beginning of January 2020. He led the CHW South Dakota through the significant growth over the first 3 years, in part due to the CDC Health Disparities Grant, funding the South Dakota Department of Health, and which they received in June of 2021. He's very, very passionate about this topic, and we're very excited to have him here to share all of the success that South Dakota has had around Medicaid reimbursement. He also has a bachelor's degree in communications and public relations from Southwest Minnesota State University, and recently completed a graduate certificate in public health from New Mexico State University. So next up is Ben.
Hello and good afternoon or good morning, everyone, depending on where you're signed in to the meeting from. I saw Hawaii enter the chat, so I know you're definitely in morning time over in Hawaii. But I'm excited to be here today to share an overview of Medicaid reimbursement in South Dakota. We are so excited to share this with you. South Dakota has learned so much from other states developing community health worker programs, and being one of the last states to develop a CHW program, we're so fortunate to have learned so much from other states, and we're excited to share all that we know and have accomplished with Medicaid reimbursement here in South Dakota. So my name is Ben Tinsvold. I'm the Community Outreach Coordinator for the Community Health Worker Collaborative of South Dakota, which launched in January of 2020 as an extension of the South Dakota Department of Health. Our mission is to promote, support, and sustain the CHW workforce here in South Dakota. So to give you a little background on South Dakota, to set the scene of where I'm at, South Dakota, if you've been to South Dakota, hopefully you went in the summer, although this winter we're having a very mild winter. It's actually a record high of 56 degrees today, but typically it'd be around 20 degrees. But South Dakota, just one state away from Canada in the Midwest, has a population of just about 920,000, so less than 1 million in population. We do have 9 tribal nations who have over 85,000 registered tribal members across South Dakota, across those 9 tribal nations. And approximately half of our population, or about 450,000 South Dakotans, live in just 2 metro areas. You can see the 2 stars on the map. I'm over on the far eastern side of the state, almost to Minnesota, almost to Iowa, in Sioux Falls, South Dakota. And then way on the west side of the state, we have Rapid City. That's typically where tourists end up when they visit South Dakota, seeing Crazy Horse, Mount Rushmore, Badlands National Park, etc. So we are very geographically rural. It's 380 miles across and 210 miles north to south. We have a speed limit on our interstate of 80 miles an hour. We go really fast because there's nothing there as far as cities and towns for much of that journey. And so it takes about 6 hours to drive all the way across, and it takes about 3.5 hours to drive north to south. So just wanted to share, I know each state is unique, and so just wanted to share a little bit more about South Dakota before I jump into our presentation here. So just to level set for everyone who is a community health worker, I'm sure everyone on the meeting today can probably answer that question. So I'm more introducing this slide to share that here in South Dakota, we utilize the American Public Health Association's definition of a community health worker. So just wanted to level set with everyone. That is the definition that we use for CHWs here in South Dakota. We do use 2 titles here in South Dakota. First is a certified CHW. This is an individual who's completed an approved CHW training program and applied for and received certification in South Dakota and works under the APHA definition of a community health worker. And then we also continue to recognize and utilize the community health representative title here in South Dakota. The first CHR program in the country actually started in South Dakota in the early 1960s. And all 9 tribal nations in South Dakota have very developed CHR programs. So we continue to recognize and utilize the CHR title. We're very excited to continue to learn from the CHR programs across South Dakota. They just celebrated 55 years of their programs. So definitely CHRs paved the way for this workforce in South Dakota. So we continue to recognize that title. A CHR is an individual who's completed an approved CHR training program through Indian Health Service and works under the APHA definition of a CHW, as well as the IHS definition of a CHR. So just to recap what our certification looks like, we do have voluntary certification for community health workers and community health representatives here in South Dakota. It does require completion of an approved training program, which is a minimum of 200 hours of training, as well as a minimum of 40 hours of shadowing. It does also require a supervisor or an instructor reference, as well as a background check, including a fingerprint background check. And to maintain certification, CHWs and CHRs need to complete 12 continuing ed units every 2 years. Certification is voluntary for all individuals in South Dakota, unless the CHW or CHR agency is seeking Medicaid and or Medicare reimbursement for CHW CHR services. I know Medicare reimbursement is very new, just starting January 1 of 2024. So we're assuming that the certification is also going to be required for Medicare reimbursement. So jumping into a timeline of work here in South Dakota, I really like to say that we were one of the last states to develop a CHW workforce outside of our well-developed community health representative workforce here in South Dakota. So really, in 2015 is when South Dakota got started looking at developing a workforce for community health workers and developing the full community health worker profession here in South Dakota. So in 2015, the Department of Health conducted an environmental scan and also conducted a statewide analysis of the CHW workforce. We looked at all other 50 states and what they were, or I should say 49 states and what they were doing when it came to developing a CHW workforce. And then we also interviewed about 45 key stakeholder organizations to better understand what the needs were and if a CHW workforce made sense for South Dakota. Overwhelmingly, the response was yes, workforce sounds great. We know that there's many challenges in developing this workforce. So in 2016, our Department of Health and our Department of Social Services co-facilitated a work group to develop key recommendations for community health workers in South Dakota. So in 2017, our South Dakota Department of Social Services, who oversees South Dakota Medicaid, drafted a Medicaid State Plan Amendment, or a SPA as we know it, and submitted that Medicaid State Plan Amendment to the Centers for Medicare and Medicaid for review. And April 1st of 2019, we officially heard back and learned that Department of Social Services, who manages South Dakota Medicaid, is now able to cover CHW services as a fee-for-service reimbursement. So it was a great win for CHWs and the workforce here in South Dakota. However, outside of our community health representatives, we didn't really have many, if any, CHWs at that time in South Dakota. So that's where in 2020, the Department of Health launched the Community Health Worker Collaborative of South Dakota. As we all know, COVID was popping up right in the early months of 2020, and unfortunately is still with us today. But from the COVID-19 pandemic, the CDC awarded states the health disparities funding in 2021. And the South Dakota Department of Health was really able to use a lot of that funding to support the initial development of CHW programs. So in 2022, our first trained CHWs began to work with patients and clients across South Dakota. And then in 2022, South Dakota voters also approved Medicaid expansion in South Dakota, with South Dakota becoming the 39th state to implement Medicaid expansion. So jumping to just last year, our voluntary certification launched on January 1 of 2023 and is a partnership between Department of Health and Department of Social Services. And in 2023, our first CHW Medicaid claim successfully processed in South Dakota on March 16th, 2023. So I will be celebrating, as will many CHWs in South Dakota, come March 16th, our one-year anniversary of having our first claims process. It really did take a few years to get everything up and running as far as getting the workforce moving and developing, and also navigating through and fine-tuning the Medicaid reimbursement process. Later in 2023, we also had additional diagnosis codes for social determinants of health approved by South Dakota Medicaid. And then July 1 is when our Medicaid expansion enrollment began in South Dakota. So here we are now in early 2024. We have over 225 CHWs and CHRs across South Dakota. We have 140 CHWs, we have 85 CHRs, and we have about 15 individuals currently in a training program who will complete their training program in the next few months. So our workforce continues to grow and develop. And so we're really excited to share how Medicaid reimbursement can really help to be part of that braided funding opportunity to help sustain these positions. So looking at our community health worker scope of work in South Dakota, this actually dates back to the 2016 work group that was co-facilitated between Department of Health and Department of Social Services. So our scope of work is pretty similar to what we're seeing in other states that have state plan amendments. We look at health system navigation and resource coordination, health promotion and coaching, and health education, specifically to teach or promote methods and measures that have been proven effective in avoiding illness and or lessening its effects. So there is a more detailed summary of each of the 3 areas of the scope of work, but for sake of time, I will just share that slides will be shared, as will the recording after the presentation today. So you'll have access to these slides and can read through the further details of the South Dakota specific scope of work. But now is the point where we're going to take a deep dive into CHW Medicaid reimbursement in South Dakota. And I've been watching the chat, and I think a lot of the questions popping up will get answered in the next few slides here. So South Dakota is not a managed care state. We just have South Dakota Medicaid. So that does make things a little bit simpler for us here in South Dakota. We just have South Dakota Medicaid, which is managed by Department of Social Services. So for a patient or client of a CHW program to be able to receive CHW services, that individual does need to have a qualifying condition and or a qualifying barrier. So this is a list of common qualifying conditions, but this is not an inclusive list. There are many other qualifying conditions that could allow a provider to refer to CHW services. And then we also look at qualifying barriers. Again, an and or situation. Qualifying barriers can be geographic distance from health services. We're a very rural state, so if you don't have a vehicle and you need to go an hour to a medical appointment, that's a huge geographic barrier. Also, if you're a wheelchair user and it's a typical South Dakota winter and we have 2 feet of snow on the ground, and we are looking at an appointment that's 2 miles away and you don't have transportation and there's snow on the ground, that's also a huge geographic barrier for that individual who uses a wheelchair. So geographic distance is not specifically defined. It's really up to that referring provider to decide if that's a qualifying barrier. In addition to that, we have lack of phone. And this is really looking at individuals going to the emergency department or not scheduling appointments with primary care providers. It's really looking at individuals who are not scheduling those routine medical appointments and instead using that emergency department or urgent care for those non-emergent needs. We also have cultural and language communication barriers, not only for those individuals who don't speak English or don't speak English as a primary language, but also just looking at communication barriers when it comes to understanding healthcare and understanding the complexity that is healthcare. And we also have social determinants of health barriers as a qualifying barrier, looking at all of those barriers to your health that are not directly your health: food, transportation, housing, childcare, etc. So this next page has a lot of information on it, but it's one of those things where everyone asks for that information. So I just thought I'd put it all out here on a slide and we'll walk through it together. So we do use 3 CPT codes as listed on the right side of the screen there: 98960, 61, and 62. We do have the rates as well. And then the service type is either for 1 patient, or it can be for 2 to 4 patients or 5 to 8 patients. Group rates are used, or group CPT codes are used and billed when it is a group who's receiving education or when it's a family. So for example, if it's a mom and 2 kiddos and both children are Medicaid recipients and mom is receiving services to address food insecurity, that would be billed using that group rate because both of those children are Medicaid recipients. So that's how the group rates are used, not only for group education, but also for families as well. So there are some limitations. There's no more than 4 units or 2 hours of service per day. There's no more than 104 units or 52 hours of service per year. And up to 5 units can take place in the clinic setting. This really allows CHWs to build rapport and connect with patients before they transition into the community or home setting to continue to provide services. So beyond the 5 units or 2.5 hours taking place in the clinic setting, CHWs are also able to attend appointments with patients. That does not count against those 5 units. So beyond that, services need to take place in the home, the community setting, through telehealth, or if there's a documented barrier to telehealth, then through a telephone encounter. We can look at many different documented barriers, from not having cell phone reception to not having the understanding of how to use telehealth, or not having the right equipment, such as a smartphone for telehealth, to be that documented barrier to allow a telephone encounter. So we do, through South Dakota Medicaid, have the requirement that providers need to have a referral and a service plan in place and sent over to the CHW program before services can take place. We do have the 3 CPT codes with their 1 unit rate listed on the table on the right side, but overall, we're looking at an hourly equivalent of $64.86 in reimbursement per hour. So we do have a very high reimbursement rate here in South Dakota, and I'll talk about that a little bit later, how we got to that rate. But overall, that's the very basics of what it looks like to bill for Medicaid. We do have a few more updates as well. We have our full billing and policy manual that shares a lot more information. This is public facing, so when the slides are sent out, you can use this link on the bottom, and you'll be able to access the billing and policy manual. But we do require that CHW services be provider ordered. Currently, providers in South Dakota are defined as an MD or DO, so a medical doctor, a physician's assistant, a nurse practitioner, a certified nurse midwife, or a dentist. We also require that CHW services must be provided by an enrolled CHW agency. A question I saw in the chat that really relates to enrolling as a CHW agency is that our individual CHWs do not have to obtain their own type 1 NPI. Instead, the CHW agency employing the CHWs applies for a type 2 or organizational NPI. So that is the big part of the enrollment process, is obtaining that type 2 NPI, a new type 2 NPI number specifically for the CHW program, then enrolling with South Dakota Medicaid as a CHW agency, and then submitting policies and procedures, one of which is noting that all of the CHWs or CHRs providing services are certified. So that's a big piece as well, is that any CHW or CHR providing services through a CHW agency that is billing Medicaid, those individuals do need to be certified. Again, telehealth is billable with telephone encounters, billable with the documented barriers. And then social determinants of health Z codes were introduced with our Medicaid program back in July of 2021. So this really allows South Dakota Medicaid to gather better claims data for the referral reasons for CHW services. Really, the example of where this came from was a kiddo and her mom went to a provider for an ear infection. The child had an ear infection, and during the visit, mom noted and shared with the provider that they were food insecure and currently unhoused. They were living out of their vehicle. So the provider put in a referral and a service plan for CHW services to address the food insecurity and housing insecurity. However, when it came to billing, those diagnosis codes for the ear infection weren't matching up. So we now are able to have CHW programs in South Dakota have social determinants of health diagnosis codes as the primary diagnosis code on that claim. So it's really important. It helps us collect better data, both for the organization submitting that claim and also for Medicaid as a whole. And so that really allowed for better claims data and better analysis of why are patients and clients being referred to CHW programs. A couple of other things to note, this is not only for medical clinical programs, but here in South Dakota, we also have community-based organizations that are able to and successfully billing Medicaid. We also have cross-trained programs such as EMTs who are also cross-trained as CHWs. We have dental programs that employ CHWs and are able to bill Medicaid. And then in South Dakota, our federally qualified healthcare centers, or FQHCs, are also able to bill Medicaid here in South Dakota. And we also were able to have our first CHR program successfully bill Medicaid just 2 weeks ago. So CHR programs are also able to bill Medicaid as well. So that's really a quick overview of the reimbursement basics. One of the takeaways I want you to take away from this presentation today is to take a look at that link and go into that link and pull up this billing and policy manual. This really goes through all of the fine details of what the billing and policy manual looks like and what billing looks like for South Dakota. I know many other states are interested in looking at that. So we're excited that our Medicaid allows us to have that public facing. It's also accessible on our Medicaid website as well, but it's much easier to find through this link. And I think Aurora saved everyone a couple steps here and she just put the link in the chat directly, so even better. So I wanted to jump into some lessons learned from Medicaid reimbursement here in South Dakota. I think there's many important takeaways. One of the things that we've really focused on since day one here in South Dakota was not only ensuring that our CHR programs would be able to bill Medicaid and would not have to complete additional training or make any big changes to their program to be able to bill Medicaid, but also ensuring that our community-based organizations are able to bill Medicaid as well. We know that CBOs are so important when it comes to the support that they provide to individuals, and many individuals access CHW services through community-based organizations. So as far as lessons learned, one of our biggest lessons that I'd like to share is just having that continued communication with your state's Medicaid program. Here in South Dakota, we're very fortunate to be a small state, and so we have to work together, and I always say we're either related or neighbors or both. And so when we look at it from that perspective, it's really all about that communication, being able to connect and maintain a relationship with your state Medicaid program. We're very fortunate here in South Dakota to have a policy strategy manager, Ashley Lowing. So shout out to Ashley. I call or text her or email her multiple times throughout the day with all kinds of questions, as do our CHW and CHR programs. And so she really is there to be that connector to Medicaid, answer those questions, and also someone for us to really communicate to and translate CHW work to policy changes. In connecting with Medicaid and being as connected as we are, we're also really able to focus on what Medicaid supports are needed to ensure that our CHR programs and our CHWs at community-based organizations are accessing and able to access Medicaid reimbursement. So when it comes to that communication, it's not only important to start having that communication when you're looking to hopefully work with your Medicaid program to look at reimbursement, but beyond that, it's really looking at taking the lessons that you're learning as you're starting to implement reimbursement and start to translate that into policy changes. So one example I already shared was the social determinants of health diagnosis codes as a primary diagnosis. That really expanded the opportunities for billing as far as the diagnosis goes, and also referral opportunities are much easier to do when you have opportunities to use those social determinants of health Z codes. In addition to that, we learned that as community health workers were starting to bill Medicaid, one of the barriers was that provider referral. Previously, up until December 1st of 2023, there was a requirement that the referral needed to come from a primary care provider or a dentist. But as of December 1st of 2023, that has expanded to now allow for a referral to come from a provider, so any provider who has seen the recipient, the Medicaid recipient, in the last 90 days. So a huge example of where that makes a huge impact is when it comes to referrals that might come from an emergency department or a hospitalist or a specialist that the CHW is seeing. I'm sorry, that the patient is seeing, who can then refer to the CHW. So one of the two CHWs from South Dakota I have joining me today in just a few minutes. She works a lot with CHWs who are receiving referrals from, I'm sorry, she works as a CHW with a lot of patients receiving referrals from emergency room providers. So through this change, she's now able to receive those referrals and service plans from those emergency room providers, provide CHW services, and then her organization that she works for is able to bill Medicaid for those services. One of the other things that we really looked at and communicated with Medicaid was rate setting. Originally, June 1 of 2019, the hourly equivalent rate was $40. However, we heard over and over again from CHW agencies that that rate was not sufficient to cover the costs of the billable visit because CHWs are going out into the community. They're going out into the home. They're going to meet the patient, the Medicaid recipient where they're at. And so when you look at it for a clinic setting, it's very easy to go from exam room 1 to exam room 2 to exam room 3. But when you're out in the community and where you're connecting with individuals in their home, you do have to really take a look at driving across town from one home to the next or driving 20 miles down the road. So we've been able to work with Medicaid to increase the reimbursement rate. It jumped 2 years ago to $60 an hour equivalent. And through the annual increases in the Medicaid reimbursements, it's now up to the $64.86. So that really covers not only the travel time to and from appointments, but also some time for documentation, follow-up phone calls, etc. So I'm going to quick jump into a little bit about how we can really put this into action to continue to sustain CHW programs. So really first looking at the cost savings and how that fits into a budget, and then wrapping up with some success stories from CHWs in South Dakota. So I'm hoping that my screen changed to a spreadsheet. If it didn't, please let me know. But this is a tool that we're able to use here in South Dakota to really help programs understand how that Medicaid reimbursement is really braided in with other funding or cost saving opportunities for CHW sustainability. So we're just going to walk through this start to finish. This was something that we built out here in South Dakota to really take a look at how we can work with programs to understand this. We can get the spreadsheet as well shared. I will say somewhere in here, there's the hidden $64.86 that makes all of the equations work. I will find that and highlight it in yellow. So if you're trying to adapt this for your state, you'll just need to put in your hourly equivalent, and then it should all translate, assuming I built out the spreadsheet correctly. But we're going to start here with the CHW salary and hours. So in looking at this, we know that CHWs have an hourly rate that they're typically paid. But in addition to that, they hopefully have benefits and other expenses that go along with their position. Here in South Dakota, we really focus not only on a livable wage, but a thriving wage for our CHWs. So we're seeing an average wage here in South Dakota of about $19 to $22, $23 an hour. So in this situation, if the CHW's hourly rate is $19 per hour and benefits are estimated at 30%, we would put in $24.70 for that total CHW hourly rate. So I'm going to put in $25 just to make it easy. You'll see this calculates everything here. So as you put in that hourly rate, you can actually do this for each individual CHW if you'd like, or you can do it as an estimate. But if we put in the $24.70 from our $19 analysis, this is showing that per 8-hour shift, we do know CHWs often work much more than 8-hour days, but for the sake of this, we're going with the 8-hour workday. The cost to pay that CHW's salary and benefits is $197.60 per day. If we jump over here and look at the Medicaid reimbursable hours per day, for example, in this scenario, if this CHW has 2 out of their 8 hours billable per day, we see that number drop significantly. We also could change this number depending on how many billable hours that CHW is able to bill for on average per day. So we'll bump this up to 3. So 3 out of your 8 hours being billable, that remaining difference for the day is now only $12.26. We do know that we don't work 52 weeks out of the year. We have vacation time, sick time, continuing ed time, etc. And so out of the 52 weeks in a year, we're going to put in 47 weeks. So that leaves 5 weeks for vacations, sick time, continuing ed, etc. So this leaves us with the remaining annual difference of negative $7,821. I already pre-filled this in with what mileage might look like for a community health worker and what a cell phone might look like and what other supplies might look like. So in this situation, we're looking at a total of $11,000 as the remaining annual difference. So if we jump over here to the pie chart, which takes a second to load, that pie chart will show how much of that total position is covered through that average daily hours of reimbursement. And I'm not sure if my pie chart is going to show it, might be a little angry at me for some reason. But if we look at this, $11,000 is something that a program could work to collect that funding from grant sources, from the overall program's budget, from equating to cost savings and other savings that an organization identifies by having a CHW working with their patients or clients. So really, when you break it down and you work through the number of Medicaid reimbursable hours per day, that can really help to significantly offset the individual CHW salary as well as the expenses as well. If you work in a facility or organization that has a high Medicaid population, you could even look at what does $4 or 4 hours look like. That's actually going to give you a positive number. When we subtract out some of these additional CHW related expenses, we're still at a positive number as well. So that's looking at an additional small amount that can cover the billing staff, that can cover office supplies, that can go towards office rent for your CHW, a new laptop or computer each year, things like that. So we will have this shared as well, so that programs can use this and be able to put in their hourly equivalent rate and then be able to do these calculations as well for their organization. So jumping back over to the presentation, I just want to wrap up with a few success stories here from South Dakota, from CHWs who are able to join us today from South Dakota. First, we have Alyssa Olson, who's a community health worker and an EMT with Brookings Health System in Brookings, South Dakota. And so I just wanted to have Alyssa share an example of one of her success stories and how Medicaid reimbursement is able to offset her wages as she provides services to this individual who she'll share in that success story. So I will turn it over to Alyssa.
Hello, everyone, and thank you for the opportunity to share with you today. I received a referral for a patient who was frequently using the emergency department. On one of those visits, she was admitted to the hospital and diagnosed with failure to thrive. So this particular patient was experiencing a lot of social determinants of health barriers and then also a significant lack of support and education. The patient had a long history, approximately 2 years or so, of turning down much needed in-home services. And upon this hospital admission, we did discover that the reason for this was that she did struggle with hoarding and she was afraid of letting others into her home. I was able to visit with her while she was still in the hospital, which gave me a great opportunity to start to break down some barriers with her. We started developing a relationship and worked on building trust before she even left the hospital to go back home. We spent some time discussing the shame, guilt, and fear that she was feeling. I really wanted her to know that my intention was to help her and not judge her, and so that was very important. I reinforced this by letting her know that if she did decide to let me come over for a home visit, that I didn't need anywhere to sit in her home, that I could just stand if that's all the space that she had. And in the end, she did agree to let me come to her home for a visit. I also reinforced with her the benefits of skilled home health services, and I asked her to reconsider letting those individuals come into her home as well. With the foundation of trust that we had built, she did make the decision in the end to accept all of the in-home services that were offered. So along with the collaboration from home health, we worked through a lot of those social determinants of health barriers with the patient. The patient reestablished care with their primary care provider and also a mental health counselor. She is now regularly taking her medications and consistently checking her blood sugar. Was able to get an emergency response system set up, making things safer for her. And then also got her set up with senior meal delivery daily, so her dietary needs were met. She also hired a cleaning agency to help her declutter her home. She's now back to sleeping in her own bed after months of sleeping in a chair due to her bed previously being inaccessible because of the hoarding issues. We all know that a good night's sleep can really help a patient's health. The plumbing in her own home was also fixed, allowing her to bathe regularly, which greatly increased her self-confidence and overall health. And she also now has clean clothes that she's able to wear. I've seen major improvement overall in her physical and mental health. She's actually improved significantly enough that she has returned to driving, which has greatly increased her independence overall and access to other community resources. And she is no longer seeking care in the emergency department.
Thanks, Alyssa. So that's just one example of how Alyssa is able to work as a CHW, but also through that provider referral and service plan, her organization is able to bill Medicaid for her time when she is working with a Medicaid recipient. So my other CHW from South Dakota who's joining me here today is Paige Welling, and she is with Cottington County Community Services in Watertown, South Dakota. And she has bragging rights, being the first community-based organization in South Dakota to bill Medicaid for CHW services. So I'll have Paige share her success story and walk us through the services that she provided to one of the clients of Cottington County Community Services.
So hi everyone, it's nice to be on the webinar today to just kind of learn more and present to you guys. I had worked with a 47-year-old woman. I've actually on Tuesday was a year ago today, or on Tuesday has been a full year that I've been working with her. She had various health challenges that required some attention, including diabetes, PTSD, depression, anxiety, high blood pressure, low potassium and low magnesium. She faced borderline intellectual disability, which influenced her overall health and well-being, and capacity to manage her own conditions. Her health started declining, so she stopped taking all of her prescribed medication, and wondering if medications might be causing her to feel sick. So I offered to attend a doctor's appointment with her, which she agreed to, and to learn more about her health conditions and to help her to facilitate that healthcare support and just be that support for her. I learned that she misplaced her glucose meter, and she stopped monitoring that as well, and so her levels were super high. And she just was not regulating her blood sugars. They were going from like 400s, and yeah, it was super high. And then we finally found her meter, and it was going from 400 to a low 200. This process didn't improve her health, but it improved her overall sense of well-being, and being able to help her support. So we with our community-based organization, we have a program called Impact, which is individuals making positive actions can thrive. So she enrolled in the program of February of last year, and then she wanted to get her GED. So we did education in May of last year, and then I attended those appointments in June of last year, and then she eventually started a job. And so she started at Casey's, and then she wanted to find some better housing. So we submitted some income-based housing applications in June. And then we kind of just kept checking back in and out with the healthcare piece. And then she also wanted to make payments on her collection or her bills and collections. So we started doing that in August. And then she was accepted into housing in September, and then she moved into her housing unit in October of last year, and she actually has a different job now and loves her job and is gonna be doing some other different things and continuing with GED. And so yeah, she's very excited about everything.
Thanks, Paige, for sharing. It's exciting to hear just how full circle this goes from the Medicaid reimbursement, what that looks like, to some of those lessons learned that have helped to fine tune the Medicaid reimbursement, all the way to examples of CHWs here in South Dakota who are not only accessing that Medicaid reimbursement, but also making huge impacts on individuals' lives here in South Dakota. So we're 1 minute over where I wanted to be for Q&A, so I will call that a win for time management for our presentation here. I usually am a talker and could talk for hours, so I'm glad we made it to the opportunity for some Q&A to wrap things up. So with that, I did just want to share my contact information. If you have any further questions that don't get answered, feel free to reach out. I'm super excited to share what I can and what I know. If you had asked me 10 years if I would be this in the weeds with Medicaid reimbursement for a community health worker program, I wouldn't even know where to start. But now I'm so passionate about it and so excited to share the successes here in South Dakota.
It looks like we have Keisha raising her hand. Keisha, if you want to come off mute and ask your question.
Thanks, Aurora. It's Quisha. Thank you so much. This has been a wonderful presentation, Ben, Alyssa, and Paige. I think I said everybody's name. So a couple of questions. The first question is, could you explain a little bit more to me the NPI-2?
Sure.
Because what I'm specifically thinking about is if a CHW works for two facilities, or if they do their own thing on the side, will they be able to also have their own NPI and then also the organizational NPI? So if you'll just explain a little bit more of that for me.
Sure. So right now, if an individual did want to work for multiple facilities, it would just depend on which facility they're wanting to bill through for that billable visit for a Medicaid recipient. That would then use that organization's Type 2 NPI number as the billing NPI. We do know that CHWs look to work independently or without having that agency who is there to process the billing, things like that. So that's a conversation we've started to have with our state Medicaid program. I would say that's our next deep dive into turning some of our understanding with reimbursement into hopeful policy changes. But overall, it really does allow a CHW to work at multiple locations. They would just at organization A and organization B, both would have their own Type 2 NPI number, both would bill for services taking place at those two places, and then working towards how we can look into CHWs working individually apart from a CHW agency as well.
Great, thank you. The second question is, it's great to get the CHW success stories. I mean, you guys are doing wonderful work, but as someone that works with organizations that's always trying to sell leadership on the ideal of incorporating CHWs in the organization, do you have any stories from organizations that are employing these CHWs? Any success stories, how they're showing the ROI, the bottom line is impacted, et cetera?
Absolutely. So it's great to share those success stories, but it's also broader than just the individual impacts. It's what is the organizational impacts. So for example, I know Alyssa in her program, the emergency department is really appreciative of her program. The emergency room providers, it's a smaller community. The providers, the nursing staff, the other support staff in that emergency department, they're all so appreciative of her work because it gets so frustrating to be an emergency room doctor and see that same patient over and over again and wonder, what am I doing wrong? How can I help this individual? And so by Alyssa working with individuals who are frequent utilizers of the emergency room, they're seeing a decrease in those individuals returning for non-emergent needs. That also then helps them to see other patients who do have emergent needs sooner. So the patients who are there for emergencies are being seen quicker, and they're more appreciative of the emergency department and its efficiencies. So I would say that's one example. I think the other example, just last Friday, as a husband of a lady who had had a stroke and was in a rehab facility for a while, her husband had worked with a community health worker, and he was fearing that they were going to lose their house. So he was able to go in and just wanted to, again, say thank you to the CHW. His wife was doing much better. And he just wanted to say thank you for all of her help and navigating through those medical bills and getting those decreased and written off. And the CHW was out in the field working. And so the supervisor talked with him instead. And she shared with me on last Friday, she was just in tears by the time he left because she realized what an impact the CHW had not only on him, but on his wife and their family. So I think there's countless stories. A lot of organizations, it really comes down to the money. And so that's where we have that tool that can really show Medicaid reimbursement is not the only answer for sustaining a program, but there's certainly opportunities to braid in that funding.
Great, thank you.
Yes.
Thank you, Ben and Quisha. Next up, I have Tiffany. Would you like to come off mute and ask your question?
Hi, this is Tiffany, and I am in Mount Sterling, Kentucky. I have community health workers, and we work for FQHC. So, of course, Kentucky just got this rule in place in July of 23. So we haven't been billing very long here in this state. So my question is around your billing note. What is in your notes, or what type of notes do you go by? Like, we work off of an encounter plan. So the thing that I'm really stuck on is what all needs to be in my note or in my encounter plan.
Great question. So South Dakota Medicaid does list the minimum requirements for documentation when it comes to documenting a CHW appointment or encounter or visit. I know everyone has a little bit of a different term for working directly with the patient or client. So in that billing and policy manual that was shared, don't quote me, but I think it's on page 7. There's the bulleted list of the minimum requirements for that documentation that CHWs have to follow as they're documenting in their records.
Okay. All right. Thank you. I appreciate it.
Yes.
Thank you, Tiffany. Next up, I have Shelby. Please go ahead and ask your question.
Yes, thank you. So I work for a tribal organization in Michigan. And so this is something we're just exploring now. But what we're finding is we have Greenway Energy. So I don't know if you work with any organizations in South Dakota that use that EMR system. But what we're finding is if we put our individual CHRs in there, they have to be like put in under a provider to bill for them. And that is going to cost us more money than what we would be reimbursed. So we're trying to see if there's a way around that where maybe me as the supervisor can be listed as the provider and I sign off on my CHR's notes. So I don't know if you've encountered that same or similar situation and have any insight on that.
We haven't. I'm jealous that the CHR program that you're working with has an EHR. A lot of ours don't, and so they're still doing more paper documentation and manually submitting claims. So I unfortunately don't have a good answer for that. I guess it might look at how those claims would be submitted for the CHR program that you're working with. If it's something where you're manually entering in the claims and submitting them like online through a Medicaid portal, or if you're sending over e-claims through that EHR? That would be a couple questions I would start to take a look at to be able to see how that claim or how that visit can turn into a claim that can be billed to Medicaid.
Okay, thank you. And yeah, when you said the type 2 NPI, I wonder if that's something we could explore too, like if that's me that has that, or our organization. But
Yeah, that would be another thing to look at is in Michigan, do you require each individual to have a type 1 NPI number? Or does
I'm
the
not
organization
sure.
have a type 2?
Yeah, I know we had our CHRs go for the type 1, but I didn't even know if the type 2 is an option. So I'll look into
Yeah.
that.
And if
Okay.
not, that might be a conversation to have with your Medicaid team in Michigan.
Okay.
Let's
Thank
do
you.
this an easier way. Here's an example.
Yes, thank you.
Thank you, Shelby. Jasmine, would you like to come off mute and ask your question?
Yeah, sure. Ben, I'm probably gonna have to email you and pick your brain quite in a bit more detail. But I was just wondering if you've identified reimbursement opportunities through FQHCs, because our local Medicaid has told us that it's part of, or that the CHW payment should be included in like the bundled payments to FQHCs, and so we haven't been able to use our like fee for service.
So we do have FQHC's billing. I can send you the language if you reach out to me in an email from our Medicaid team. It's actually somewhere on the Medicaid website. I don't have the direct link this second, but it explains the language that you're looking for, where FQHCs are able to receive the fee for service rate as this goes beyond the bundled payment.
Wow, that's incredible. Well, and I'm in Indiana, and our 98960 reimbursement rate is $9.60. So it's totally underutilized, but we're still trying to make a case for something happening here. So thank you. I'll reach out, Ben. Thanks.
Awesome.
Thank you. Next up, we have Sarah. Please feel free to unmute and ask your question.
I think this might go a little bit into what was just asked, but I was looking at the state plan amendment that allowed for the CHW services to be covered, but it doesn't include the breakdown of the cost. And where was that another plan amendment, or where is that located in that language?
So those costs are not directly in the state plan amendment for South Dakota because they do change and did change because of our connection with Medicaid. So that's on our website as well. It's also found on Medicaid's website. I just know where it's linked on ours. So if you reach out to me, I can quick send you the link too, where it goes through the fee schedule, which changes every July 1.
Okay, thank you.
Thank you for that question. And Ben, I'm going to pass it over to Tasha for one of the questions we've had come up in the chat.
Sure.
One of the questions was, can a CHW receive referral from a behavioral health provider? Wanted to see if you could provide some clarity on that. I saw that question a couple times.
Sure. So if the behavioral health provider is an MD or DO, a nurse practitioner, or a physician's assistant, they are able to refer. We have looked and connected with Medicaid to see if other behavioral health provider types, for example, a licensed clinical social worker, could refer to CHW services. Unfortunately, the response that we found from South Dakota Medicaid is that to make that change, it would need to go through legislation in South Dakota, because it would be changing the codified law in South Dakota as far as who is defined as a provider for referrals for Medicaid. So we've gotten that far with it. And now it's looking at, are there agencies or organizations that are wanting to take on and move that forward through legislation to make that change.
Thank you so much, Ben. We have our Q&A has finished up just in time. I want to say a huge shout out to Ben. Thank you so much. You've been so generous with your time and sharing out your resources. Huge thank you to Alyssa and Paige for coming on and sharing your story. It is so great to hear about the incredible work that's being done. Thank you for everyone who's attending. If you like this event, please feel free to fill out our post-webinar survey. Let us know what other events you'd like. If you want to hear from other states, if there are specific resources, please let us know. Because we want to be a resource for you all. Thank you so much for the NACHW staff who have been here supporting today. We will definitely be sharing out all the slides, resources, recording with everyone who registered. So we really appreciate it. Please keep a lookout for your email for more events coming up. We appreciate it. Everyone, please stay happy and healthy. Have a great rest of your nights.